are excited to share with you. So my name is Amy DeLong. I'm the manager of federal government relations here at Boston Children's. And I'm going to introduce the panel that you'll be hearing from, talking about some exciting work that is happening. Seated right here, we have Dr. Sharon Levy, who is the director of our Adolescent Substance Use and Addiction Program, known as ASAP. Dr. Levy helps to establish ASAP, which is an outpatient program based here at Boston Children's Hospital and run by pediatric addiction medicine specialists who can handle the unique circumstances of addiction in young people, which differs from addiction in adults. The ASAP team does amazing work, and we are really fortunate to have them here at Boston Children's. Seated just over here is actually Dr. Sharon Levy's husband, Dr. Ofer Levy, both doctors at Children's in different specialties and substance use disorders and vaccinology, who I imagine until recently you probably didn't overlap very much in your work here, but now you're leading this shared project that we're here to talk about today. Dr. Ofer Levy is the director of the Precision Vaccines program here at Boston Children's. He's a pediatric infectious disease specialist. And you've likely heard of precision medicine and the concept that medicine can and should be tailored to the needs of distinct populations, like, for example, the very young or the elderly. This program led by Dr. Levy applies that concept to vaccine development, and he'll be talking more about that. And here we have Dr. David Dowling, who's a faculty member who works in the Precision Vaccines program with Dr. Ofer Levy and focuses on tailoring vaccines. He'll talk in some detail about how they're working together to optimize the success of an anti-opioid vaccine for use in the adolescent young adult population, the very people who are coming to Dr. Sharon Levy and her team for help. So I will first turn it over to Dr. Sharon Levy, who will talk about the challenges that opioids have posed to her patient population and the work taking place in ASAP.
So I want to thank you for your time and attention. This slide is just showing us a little bit of epidemiology. I think probably everybody looking at the slide knows what a tremendous problem opioids have become. This is showing us on the left the different opioids and the mortality risk associated with them, and on the right the overall mortality. And as we can see, those lines continue to climb. And currently, more than 100 Americans die each and every single day from an opioid overdose. So back in 2000, here at Children's Hospital, we opened the Adolescent Substance Use and Addiction Program. And by 2004, we had started treating adolescents with opioid use disorder, including using medications. A couple of years later, we published a little bit about our experience describing some of those first kids and how their treatment really differed from the treatment of adults with the same problem. And what's really striking to me in my memory is that when we had first submitted the paper for review, comments from reviewers came back and said, how could you possibly treat younger people with medications when we don't know what the long-term impact of these medications are on the developing brain? Their point was well taken, but we knew we were looking at kids who, without medication, were likely to overdose on opioids. In fact, one of the first patients I treated, who's described in this paper, had actually overdosed and was put on breathing support in the intensive care unit twice before he got started on medication. Things really have changed. This is a statement from the American Academy of Pediatrics that was published in early 2017, recommending that pediatricians actually prescribe medications to treat opioid use disorders in their adolescent patients, and that for pediatricians who are not prepared to do so, to be ready with referrals so that younger patients could get this life-saving medication. Now, this slide is from a large national study called Monitoring the Future that surveys kids in 8th, 10th, and 12th grade every year to follow trends in substance use. And here we see a little bit of good news. What we're looking at is the percent of kids who tell us that they're using Vicodin, which is an opioid pain medication, non-medically each year. And you can see that starting in about 2010, that line starts to drift down and continues to do so. In 2018, we had some of the lowest levels of non-medical opioid use reported by high school kids. So that's really good news. But unfortunately, we're just not out of the woods yet. So this slide is looking at the rates of opioid overdose amongst kids aged 15 to 19 in the US. And you could see that even as the rates of prescription pain medication, non-medical use are drifting down, the risk of overdose death is still drifting up. And that's because the drugs that are available, even though fewer kids are using these substances, the substances that are available have become much more potent and in fact much more lethal. And so it remains important to treat adolescents. We know from the work of colleagues that adolescents are much less likely to get any form of treatment for substance use disorder, including opioid use disorder, than are their counterpart adults. And so one of the great efforts of the Adolescent Substance Use and Addiction Program is really to spread the model of care that we do at the hospital throughout the state. And we do that by integrating substance use care right into primary care pediatrics. We, at this point, have about 9 practices throughout the state that have started doing versions of this work so that we can support children and families who need opioid use disorder. And this is a really critical component because when you think of treatment for opioid use disorder, as with any other disorder, we want to treat kids in the least restrictive environment possible. Often we think about, when a child's identified with an opioid use disorder, we think about looking for a hospital bed, but we know that for most of these kids, we can treat them right in their communities. We really have to get a medical component, which includes medication and other kinds of medical follow-up, as well as counseling support and peer recovery support. And this new project is really an opportunity to build a 4th arm into the 3 arms that are used to treat opioid use disorder by protecting patients against opioid overdose. And I think I would stop there.
Great, so we'll transition to Dr. Ofer Levy, who will discuss the Precision Vaccines Program. And I should also mention, folks who are watching online, you can use the chat box by pressing the More button on your screen. If you have questions that you'd like to submit, we'll be doing a significant Q&A portion after each speaker presents.
Good afternoon, my name is Ofer Levy, and the title of my talk is Precision Vaccines, Bringing Precision Medicine to Vaccinology. I'm a physician scientist in the Division of Infectious Diseases here at Boston Children's Hospital, and I direct the Precision Vaccines Program. My email and our Twitter handle up here. So a major epidemiologic observation that really drives a lot of our work is, as infectious disease physicians, is that infectious causes of death are most common in the young and elderly. Here on the y-axis, we're plotting the number of infectious cause deaths in the world, and on the x-axis, the age of the individuals who are dying. And as you can see, it's a very much a U-shaped distribution, which is particularly steep in early life and then comes up again in the elderly. And this has been known for a long time. You know, we could look at something like this and just say that's too bad, but we have a team here that's really determined to do something about it. And of course, one of the key ways to prevent infection and other diseases is through immunization or vaccination. Vaccines were typically developed with a one-size-fits-all approach, assuming that the vaccine formulation would act more or less the same way, whether it's given to a man or woman, young person or elderly, in one season or another, alone or with other vaccines, giving a live vaccine or a killed vaccine, or given the same vaccines in different parts of the world. But it turns out that all those factors can have a big impact on the immune effects of a vaccine and whether it actually protects against disease or infection. With these considerations in mind, in 2016, Boston Children's Hospital created the Precision Vaccines Program, which I direct. And it's based here in the Division of Infectious Diseases. Our research is supported by NIH, but we're also supported with some internal funds and philanthropy. The program is really a platform to enhance collaboration between academia, government, and industry to accelerate development of vaccines for vulnerable populations. We have a faculty and scientists based here at Boston Children's of about 35 individuals, faculty, research associates, postdocs, etc. and a network, international network of individuals called the Precision Vaccines Network, who receive our quarterly newsletters. Now we're close to 400 individuals who receive those. And if you'd like to receive our newsletter, hear about new initiatives in vaccinology, please simply email us. We're based here at the Harvard Institutes of Medicine building in Boston. And a few words about what precision vaccines really are. So as you know, precision medicine refers to tailoring medical treatment to individual characteristics of each patient. It doesn't necessarily mean a separate drug for each individual, but rather our ability to classify people into subpopulations that differ in a response to treatment. In this context, precision vaccines take into account the target population, whether they're young, elderly, male, female, etc., and are developed and designed to selectively activate the immune system by targeting anatomic sites, cells, and molecular pathways that generate a protective response against the infection or disease one is trying to protect against. And as needed, which is often the case in individuals, vulnerable populations with relatively weaker immune systems, these vaccines may contain an adjuvant, a molecule that's known to activate the immune system and boost a vaccine response. So what is our approach for developing precision vaccines? We take a variety of approaches. We are involved in targeted clinical trials, including phase 1 trials of new vaccines, and we obtain small volumes of blood before and after immunization and apply big data science, really cutting edge assays that measure the entire inventory of proteins or metabolites or genes that may be changing in an individual after a vaccine to try to learn the rules of immunogenicity. How do vaccines really protect? And then we do sophisticated analysis using computers and have hypotheses as to how these vaccines are protecting. And we can then test these hypotheses outside the body. We can actually model the human immune system outside the body, and we can distinguish an immune system of an infant or an elderly individual or an immunocompromised individual, or perhaps an opioid using individual, because opioids change the immune system. We can model these outside the body with blood collected from these individuals, and that helps us test our hypotheses and identify next generation vaccines. You're also going to be hearing from Dr. Dowling on our efforts to discover new molecules to boost immune responses in vulnerable populations, NIH-funded adjuvant discovery program, which leverages these same technologies as well. Lead vaccines out of these efforts can be tested in appropriate animal models and then close the loop into clinical trials. You know, what kind of innovations are we looking to create in the vaccine space? Well, these days, many vaccines require multiple booster doses before an infant, for example, is protected. You have to bring your child back to clinic multiple times, but as children would all agree, one shot would be better than 3. Can we develop vaccines that with a single shot can, early in life, can give lifetime protection? This would be one kind of deliverable, and there's all sorts of science we can do around that, molecules that activate the immune system and it can be altered to be delivered in a safe way to boost immunity. Our preliminary work in this field has drawn praise from Dr. Tony Fauci at NIAID. Our results support the concept that immunization in early life, for example, in newborns, may be possible and could be life-saving. We are collaborating with medical centers around the world, in Canada, in the Gambia, West Africa, in Australasia, Australia, Papua New Guinea, studying infant cohorts, understanding how vaccines protect in early life. And we have a project in West Africa where small volumes of blood are collected from newborns right before and after immunization. This is funded by NIH through the Human Immunology Project Consortium. And we have developed a technology called a small sample big data technology. We can collect a small droplet of blood from a baby because you're only allowed to collect a little bit, and we can split it in the lab and extract huge amounts of information, tens of thousands or even hundreds of thousands of measurements from a small droplet of blood. This will give us deep insight as to how vaccines are protecting in early life. We've already published some of these results showing these technologies are feasible and give a lot of insight into how the human body is changing early in life, and that's important for health and disease. We have a robust social media effort through the Precision Vaccines program, because in this era where anti-vax movement has harmed public perceptions of vaccines, we believe it's really important to highlight the benefits of vaccines and vaccine innovation. So we're operating on Facebook, Twitter, LinkedIn, and other platforms. Our efforts have garnered media attention in the United States and throughout the world. We were covered in Scientific American in terms of our ability to measure in small droplets of infant blood how the infant body is changing across time. And next we will study how vaccines impact that. We've been covered in the nightly news everywhere from the Philippines to Canada to Israel. and we have strong collaborations across West Africa. We have a growing number of awards from NIH and National Institute of Allergy and Infectious Diseases in adjuvant discovery, development, human immunology, and opioid vaccine development. Many of these together with Dr. David Dowling, who will speak next. I will highlight that we have collaborations and funds issued also in Chicago, Illinois, to the Infectious Disease Research Institute in Seattle, subcontracts to a company called Inimmune in Montana. We collaborate with the Southwest National Primate Research Center in San Antonio, Texas. So it's really a national and international effort. Our view for the future is we want to bring precision medicine to vaccinology, scale our impact. These vaccines are highly relevant both for US and global health. Look at a broad range of vaccine applications to infectious diseases, oncology. Many of these adjuvants that boost immunity may be helpful to treat cancer, treat autoimmunity and allergy, and as you will hear, develop opioid vaccines. We're working on new vaccines against respiratory syncytial virus or RSV, influenza, pertussis, and human immunodeficiency virus. We are now going to be involved in a phase 1 study of a new adjuvanted HIV vaccine to be given to babies in South Africa in the spring of 2020. We are robustly generating intellectual property for small business development, and we are always in search of support for a moonshot effort to leverage all this complex but costly systems biology to advance personalized vaccines for vulnerable populations. I will now hand over to Dr. David Dowling.
Okay, so that's a great overview by both Sharon and Ofer, and it makes my life a little easier so I don't have to go too much into the background. What I want to do is try and focus a bit more on the specific goal of developing an adjuvanted opioid vaccine and some of the areas which are working on around this area. Briefly, one of the things that I wanted to highlight is that there have been many revolutions in the context of vaccinology, and these have had major impacts in reducing the overall rates of infectious disease around the world. So there's a quote here from Stanley Plonkin, who's often considered the godfather or grandfather of vaccinology, indicating that vaccination or the impact of vaccination on global health cannot be over-exaggerated. And over the last 150 years or so, there have been a number of technological innovations that involve the use of attenuation, so using live attenuated organisms or killed inactivated organisms, or in the 1950s onwards, we as scientists were able to develop vaccines based around the culturing of viruses, and that led to, for example, the development of the polio vaccine. And due to the biotechnological revolution in the 1980s, recombinant technologies allowed for purification of single proteins that could be included into vaccines, and that allowed for a new wave of vaccine technologies. And since the 21st century has started, a growing understanding of immunology has really unlocked an ability to move towards a precision vaccine approach. So the goal of our current project is to develop a vaccine that could potentially protect against heroin and fentanyl. And there are three main components to this. Firstly, what we want to try and do is model in vitro in a test tube using peripheral blood from individuals who are adolescents, young adults who may have a history of opioid use disorder, and how this could inform our precision vaccine approach to select formulations that work in those populations, to then develop using various different various medicinal chemistry and engineering approaches and optimize formulation directly targeted for that population, and then to also understand in a qualitative way how this vaccine could be used in the real world by having various different approaches of interviews, etc., with both the individuals who may be targeted and their families. So the approaches we're taking right now are to try and involve technologies which are very new in the context of vaccinology in some cases. And this graph gives an overview of the various different newer technologies that people are employing in vaccine approaches. These include novel combination technologies or nanotechnology delivery systems. And what I wanted to try and highlight here was, as Ofer had mentioned, our ability to employ both adjuvant technologies and to use these in non-infectious disease vaccine approaches. So what are adjuvants? Adjuvants are molecules which can enhance an immune response. As I said before, historically, the vaccine development approach usually focused on trying to mimic a pathogen in some way using a live attenuated organism. and then moving away from that in terms of inactivated or subunit components. However, the disadvantage of this approach is, as you make vaccines safer, we may also reduce their ability to induce an immune response, which is very robust. So adjuvants may have a potential to enhance responses to vaccines in ways that we cannot otherwise induce, and to induce a more rapid immune response, and to broaden the response to various different infections or other modalities that we can't currently prevent. Vaccines for elders or the young, therapeutic vaccines in this case, which we'll discuss a bit more, or dose sparing. So there are many advantages to adjuvanticity. So to get a little bit more into the science of this, I wanted to show a graphic that kind of summarized a little bit the benefits of adjuvants, which can enhance the magnitude and breadth and durability of immune response. So on panel A, we're just indicating a traditional vaccine approach, which is non-adjuvanted. A vaccine is injected in a prime boost or potentially boost approach. It activates the innate immune system, usually through cells known as dendritic cells. These can then pass on the information that they sense from the vaccine to both your white blood cells known as T cells, and that information is passed on to B cells, which induce a antigen-specific or vaccine-specific immune response. One of the downside of this traditional approach is that you can sometimes have a very narrow antibody response and that your immune system may wane. So the idea of adding an adjuvant immunostimulatory molecule is that it can dramatically enhance your innate immune response. So you get a much stronger T cell response that's also much more broader, and that your antibody response driven by those T cells and B cells interacting can be very broad and last for a very long time, potentially the lifespan of the individual who gets vaccinated. And so there's a growing recognition at the federal level that adjuvants also may have population-specific effects. And the current NIAID strategic plan and vaccine adjuvant research that was only published last year highlights this overarching theme, indicated by the overall graphic that different populations have to be taken into consideration when trying to develop newer formulations and next generations of vaccines. And so in terms of the mechanism of action that we're trying to induce in the context of an anti-opioid vaccine, this graphic kind of sums our overall strategy, where you have a person who is an individual who is intravenously injecting an opioid that activates a reward circuit. And our goal is to try and create a vaccine strategy in which we can induce an immune response against that small molecule. And one way of doing this is to approach this using a technology approach where you combine the small molecule and bind it onto a protein of interest. And that's what you see in panel B. And this is a carrier protein. In many cases, this is a protein that's traditionally used in many vaccines for many years, often for decades. When you combine this carrier protein and conjugate or stick on the small molecules in a way and add them as a combination with adjuvant, you can induce an immune response specifically against that combination protein opioid to elicit an antibody response. And if you produce a strong enough antibody response, these antibodies could then theoretically bind the opioid of interest and prevent it from entering the brain and from the peripheral blood. And so currently the main classes of vaccines under development to prevent addiction are nicotine, cocaine, methamphetamines, and opioids. And theoretically, anti-opioid vaccines may have the potential to sequester the drug peripherally and prevent, as you said, the opioid from reaching the target receptor in the brain. And theoretically, the vaccines, in this case, an anti-opioid vaccine, will work through a process of competitive antagonism. In essence, the vaccine would induce antibodies that block the function of the opioid, which means that the use of the drug of abuse could still theoretically override the blockage of the vaccine. And so we have to consider that in future developments. In addition, as Sharon Levy can talk to with more authority, is that anti-opioid vaccines are medications which probably potentially have the potential to prevent relapse, but also need to be used most likely in combination with other interventions that she mentioned, including behavioral interventions. And one of the areas that there's growing interest in is that individuals, as Ofer had said, who have come from or have distinct backgrounds and may have distinct immune responses to various different medications, including vaccines. And there's growing interest in understanding how various different opioids, including heroin, fentanyl, and morphine, for example, may modulate the immune system, including the innate and adaptive immune response. So we believe it's critical in the future to begin to model and understand the immune system of these distinct populations in more detail, and use that information to try and drive our decision making moving forward. So in terms of adjuvanticity, right now we only have two traditional adjuvant systems that are available for most vaccine development systems, and these are alum salts and oil and water emulsions. And what we're trying to do is discover new classes of adjuvants using various different technologies. So I'll just give you an example of one approach that we've been doing this over the last number of years, where we can collect peripheral blood from number of individuals, and then use the peripheral blood from humans to do high throughput screening on the individual's immune cells, and detect small molecules from libraries of hundreds of thousands of molecules that may have an ability to drive immune responses in both our in vitro and animal models of interest, including models that may predict adjuvanticity towards individuals who have a history of opioid use disorder. I just want to highlight the opioid vaccine team that's working on this, including myself, Ofer, Sharon, Al Ozanoff, who's a faculty within the Precision Vaccines program, a number of our technicians and postdoctoral staff, and we've a growing number of collaborators. And just to highlight, Jay Evans' team, as Ofer mentioned before, and a number of collaborators at the University of Houston who are working on some of the potential animal models that may be able to predict the most effective formulations for the history of opioid use disorder. And then we'll finish up there for discussion, I guess.
This sounds good. So we have some questions. I'm going to direct them broadly to you, and you can jump in as you see fit, who should answer. But if an anti-opioid vaccine were administered and effective, how would a vaccinated person be able to manage pain if he or she needed it for another medical reason, like they were having surgery or something like that? So
I think one question that arises with the opioid vaccine is the desirable characteristic of, right, there's currently no licensed opioid vaccine. This is a research and development project, just to clarify that. So the goal would be to create a safe and effective vaccine that blocked, for example, the ability of fentanyl to cause opioid overdose death, but that did not cross-react with other medically important opioids. So that would be something we would evaluate in our development program, wouldn't it, David?
Yeah.
Well, the other thing that I would just add is that the current treatments for opioid use disorder include molecules that actually block the opioid receptor in the brain. And that it causes the same issue that if you need to treat somebody with pain medication with those receptors blocked, you actually have to give quite a bit of a higher dose. But there are procedures and standards for doing that. So in fact, this would be relatively easier to overcome because it would only be targeting fentanyl or a small number of molecules when we have available to us many different kinds of opioids that would not be affected.
So in the big picture, we're going to conduct this research in the coming years, and one of our goals will be to create a vaccine that specifically blocks the fentanyl, but not other medically useful opioids.
Interesting. Thank you. I understand you're talking to folks with substance use disorders about the vaccine development and sort of testing their reception to it. How are you also speaking to people who do not struggle with substance use disorder, sort of outside that population to sort of test the concept?
Yeah, so we're recruiting people from a number of different groups to talk to them about the potential of using this vaccine. So obviously people who have opioid use disorder would be prime candidates. The highest risk of overdose comes when people leave a treatment program or leave jail because they lose their tolerance and often accidentally overdose. So that would be a population that would be an obvious target for the vaccine. But we know that there are other populations too. When we get out into the community, we know that there are many adolescents whose lives have been touched by opioid use disorder in one form or another. We're talking to people who have a sibling or a parent who's been affected by opioid use disorder, even though they may not have been affected themselves. We're also In our substance use disorder program, we're seeing lots of kids who don't have opioid use disorder, but have been exposed to fentanyl through contamination of other drugs that they may be using. So I think there's a lot of work to do in figuring out who would be the most appropriate targets for this type of vaccine, and really understanding what would be acceptable to young people and their parents and families.
And in the broader sense, we also see the Precision Vaccines program as using a variety of approaches to develop next generation vaccines. And those include sophisticated cellular and molecular biology that we alluded to, but they also include the psychological dimension of patient attitudes, of the qualitative research to understand. You could design the best vaccine in the world. If people don't want to take it for some reason, that's not very helpful. So taking into account that different vulnerable populations may have different views or stances towards vaccines is an important component of what we're doing. And this would be the first example we're getting into it, but probably not the last.
Thank you. Are there other vaccines marketed or in development that prevent against non-infectious diseases? This seems pretty unique.
So as we said, there's currently no licensed vaccine against drug use in general, as far as I'm aware. There have been research efforts on nicotine vaccines and other, but those are not licensed at this point. Some point can be semantic. There's a human papilloma virus or HPV vaccine. One example is Cervarix. There are others. There's Gardasil, right, in the U.S., and that's given to young boys and girls to prevent human papillomavirus. But the reason we give it is not due to the infection per se, but the consequences of the infection are cervical cancer. So in a way, that's an anti-cancer vaccine. It achieves that anti-cancer effect by preventing a viral infection.
How would the vaccine impact a person's natural ability to handle pain?
Really shouldn't have much impact at all. The vaccine would be very narrowly targeted on fentanyl, so it's really interesting that fentanyl binds to receptors in the brain that are really there because our bodies make natural opioids, and so really fentanyl is mimicking some of our body's own natural proteins, and if we have a vaccine that would prevent fentanyl from getting to the brain, it wouldn't prevent the natural opioids that our bodies make from getting to those receptors.
And we mentioned fentanyl a lot, but as I understand, also another desirable target is potentially heroin, and potentially an ultimate vaccine might target both. This is still early development phase, but those are things, the targets we're looking at. Yeah.
Well, and actually it's an interesting question because one of the, we have to understand where the vaccine would fit into the treatment paradigm. And the most obvious place to start with is that it could prevent opioid overdose and death. Because if heroin or fentanyl can't make it to the brain, can't bind to the receptors that control breathing, you have a very effective prevention tool. It's possible, and people have really conceived of broader vaccines that also protect against other opioids that could be used even more broadly in treatment, although that's really something that still needs to be understood better.
So initial phase may be to try and target what is known as a monovalent vaccine against, for example, unintentional use of fentanyl, which is a common occurrence. And Sharon could probably talk to a bit more. But then in future development is that you start creating lots of monovalent vaccines and then you try and combine them all together. And that's a traditional approach for many vaccine technologies. For example, the diphtheria, tetanus, pertussis vaccines all started as vaccines by themselves, and then they were combined together. So it might be in the short term to have a monovalent vaccine, but then in the future, if you could test the combination together, that would be helpful.
Another question just came in is, can you talk a bit more to the public policy challenges and opportunities around precision vaccine research and development?
Well, thank you for that. I'd be happy to. I think this is a topic whose time has come. You know, precision medicine has been out there as a critical concept, but applying it to vaccinology is not as commonly discussed. And I think the time has come for that. I mean, it is very evident. We know that certain vaccines will protect you at a certain age, but not another age. If you look at the pneumococcal polysaccharide vaccine, for example, it may have some effect in adults, but in newborns, it has no protective effect. So there's now a strong rationale to be much more precise about how we develop vaccines and how we target them for vulnerable populations. And the case is being made that rather than developing vaccines as a one-size-fits-all, and then and always targeting a middle-aged adult and then saying someday we will march down the clinical trials to a newborn or to somebody with opioid use disorder or an elderly individual, we might need to turn the process on its head and say, if we are developing a vaccine against a given disease, and if that disease is common in a certain population, let's take that into account at the start of the project. And let's be able to model that human immune response outside the body with blood. That's a huge win because, you know, if you think about all the diseases we want to protect against, HIV and RSV and Ebola and opioid overdoses, and, you know, the list goes on, and you think about all the candidate antigens and all the candidate adjuvants, the boosting molecules, and the different ways of putting those together, and the different populations, men, women all over the world, young and old, etc. It's not going to be possible to do large-scale phase 3 human in vivo clinical trials for every combination. So systems that are better at predicting matching the vaccine formulation to the target population outside the body, the kind of human in vitro systems that David and I and others in the program work on, and others at other medical centers, we think will be a key part of the equation in moving this field forward. We also think that precision vaccinology can be a paradigm or a theme that can get the vaccine discussion in the public sphere back on common ground. Acknowledging that certain vaccines are more optimal for one population or another, and keeping that in mind, you know, safety and efficacy of vaccines and using the most cutting edge technology to that end, I think can help push restart and refresh on the public discourse around vaccines.
And just to kind of follow up on that, maybe it's good to highlight maybe two potential benefits that I think, you know, policy advocacy has helped in many cases. So for example, over the last maybe 10 or 15 years, there's been a big push to include both women and children into many vaccine research pipelines, and many people at the policy level have really had a big effect on the laws in this area. And then that has meant that the National Institutes of Health has pushed a lot of research to be more inclusive of broader populations. And there are still challenges. One challenge, for example, is while there's still a lot of very good funding at the basic research level to translate some of this into a clinical trial, there's a gap in the funding there. And it's very hard for researchers then to get the backing of an industry backer to take the risk in all of these areas. And so there's risk aversion in terms of the translation aspect. And that's still a debate. I think we've been a lot of NIH meetings talking about this problem, that there are lots of growing candidates and research that ourselves and others are pushing forward, but the next step of bringing it to a clinical trial or to a translational point is sometimes stalled for various different reasons.
Yeah, so many of these systems we alluded to, the systems biology, using these big data approaches, the in vitro modeling, the adjuvants, are all ways to innovate, accelerate, and de-risk vaccine development for vulnerable populations.
So related, is there any formal connection between your precision vaccine efforts and the NIH Precision Medicine Program, and what federal policy or policies could help advance those efforts?
Right, so we being the Precision Vaccines Program is largely funded by the National Institutes of Health, and our grants and contracts from NIH are largely from the National Institute of Allergy and Infectious Diseases, or NIAID. They are not, formally speaking, precision medicine awards. They're NIAID awards. Some of these are large-scale contracts for adjuvant discovery development that David leads and or manages. Some of them are grants, like the Human Immunology Project Consortium. They intellectually involve precision immunology, precision vaccines, but they're not granted under a precision medicine title. We think that much more could be done to create synergies between the formal precision medicine portfolio and vaccinology. And we think that encouraging NIH along those lines and building programmatic synergies along those lines would be a big win for public health moving forward.
I think we've gone through the questions that have come in online. If there are any we'll check after, make sure we didn't miss any. There may have been some going to a private box, so we'll double check and follow up with people. We encourage folks to stay in touch. There's an email address on the invite that you probably received to watch this broadcast. Allison, ALLISON.Doyle@childrens.harvard.edu works in our government relations team. And if you have questions for anyone on the panel or about our government relations work more broadly, get in touch with Allison and she'll connect you to the right folks. And we thank you for tuning in. We're wrapping up a little bit earlier than planned, but I think we were able to address some really interesting questions, and I appreciate the folks here sharing their time. We've taped this recording, so it will be shareable as well. So thank you.
Thank you for the opportunity.